Greetings. Welcome to our 10th annual athletic training speaker series and recognition ceremony at St. Louis University. So we'd like to start with Father Michael Rozier with an invocation for today's event.
Thank you. Let's just quiet ourselves as we pray. Blessed are you, God of all creation, whose very life permeates our world. Blessed are you who have brought us together as friends and colleagues. Be present to us, forming us as your people, committed to hope and healing, justice and mercy, compassion and solidarity, in a world burdened by injustice and indifference. Pour forth your blessing upon us, renew and refresh us for our mission, making us effective caregivers and leaders who can transform the world with your bountiful gifts. Bless this time we are about to share, that the words we speak may call forth the best in us all. May this moment deepen our shared sense of vocation and strengthen the bonds that unite us in love and faithful service. Amen.
Thank you, Father, and thank you for agreeing to serve on our panel later in the event. So the next thing we'd like to do is in addition to the speaker series, we make this our recognition ceremony, and for those who were here earlier, we did induct several individuals into the Auto Alpha, which is our chapter of the National Athletic Training Honor Society. But we also want to recognize our scholarship recipients, and as a part of that, we would like to remember the memory of Brandy Bridgette. She was a student in our program here at St. Louis University, and she, after a long struggle with Crohn's disease, passed away several years ago. And she had an absolute love for the profession of athletic training. If you did not know that she was sick, you wouldn't know she was sick. She rarely complained, but she struggled mightily with a terrible chronic illness. So when she passed away, Robert and Marnie Bridgette, her parents, founded the Brandy Bridgette Memorial Award and Scholarship. And we would like to, number one, recognize Brandy's memory today, as we do every year. And we would also give Robert and Marnie a chance to say a few words and recognize the scholarship award winners. Marnie, Bob.
Thank you, Tony. I hope that you're able to hear us okay as we are hunkering over my laptop together. But it is definitely an honor and pleasure to recognize, help me if I'm wrong here, Tony, Jose and Kate, correct? Yes, there we go. Okay, beautiful. Thank you, Tony. So take this time to recognize the two of them for coming forward with the proper words and to, hopefully this small gesture will make a difference in their life. And our dream is to always make a difference with Brandy's Scholarship Award Fund so that someday as the recipients go forward in life, they can then pay it forward to somebody else in Brandy's name. Excuse me. Anyways, it's really been a short journey so far and a long ways to go, but we truly hope that these two fine young students will be able to carry on Brandy's legacy, and along with all the other students, if you did know her or didn't get to know her, Tony can share more stories. All good. Anyways, we're very blessed to be part of this program and to continue giving each year so that Brandy's legacy can be remembered forever. Thank you, Tony.
Thank you.
Thank you, Marnie. Thank you, Bob. God bless you. Know that we will always keep Brandy in our hearts. Her dedication to our profession, dedication to SLU, and the type of person and daughter and colleague and student that she was will always be in our memory. So thank you so much. And we thank you for your generosity in supporting our students moving forward in Brandy's memory. So as Bob and Marnie said, this year's winners of the Brandy Bridgette Scholarship were Jose Blanco and Kate Perko. And we also have another scholarship here at St. Louis University, the Bob Baumann Scholarship, which is actually, it was founded at our initial speaker series, and Kim Tucci helped found this scholarship, and actually Kate and Jose were also the award winners of that scholarship. In addition, the SLU athletic training team won the Missouri State Quiz Bowl, and both Jose and Kate were on the team along with Joey Wenzel. So congratulations, go Billikens. We're pretty proud of that. So now I'm going to transition into, oh yeah, that's right. March is National Athletic Training Month. We will be recognizing the profession of athletic training all month in March. And this year's slogan is essential to healthcare. So, and it's very much in line with tonight's topic about finding opportunity and value moving forward as health professionals. I want to turn it over to our chair, Dr. Lisa Dorsey, for a welcome for tonight's event.
Good evening, everyone, and welcome to the 2021 SLU AT Speaker Series. I would like to say congratulations to the inductees and the scholarship awardees, and thank the Bridgette family for their generosity. We are happy to host Dr. Kathy Derringer to present this evening the emerging opportunities creating value in an evolving healthcare paradigm. This past year, as we all know, has really highlighted the changing healthcare landscape, and we are fortunate to have the opportunity to hear more on this topic this evening from Dr. Derringer and our panelists. Now I would like to introduce Dr. Tricia Austin, the Dean of the Doisy College of Health Sciences and Associate Professor in the Department of Physical Therapy and Athletic Training. As a credentialed athletic trainer herself, she is deeply supportive of the profession and invested in the future of athletic training practice. She will now share a few words with us. Thank you.
Good evening. I am not certain if my video is showing or not showing. Tony, can you give me a thumbs up one way or the other? Not that it matters.
It's not showing, Tricia.
Okay. Let's try that. Okay, perfect. A little on and off again. So again, thank you, Lisa, for that warm introduction, and thank you, Lisa and Tony, for your exceptional leadership within the department and specifically the program, athletic training program. I also would like to thank our students, our faculty, and our staff who make the program what it is, as well as our alumni and supporters who diligently contribute in many ways to make the program as strong as it is. So it's my pleasure this evening to join in the capacity as Interim Dean of the Doisy College of Health Sciences. Exceedingly grateful for the opportunity to see this event continue to move forward in the set of circumstances that we find ourselves. That's COVID, that's weather, that's all kinds of different things that permeate it, but nonetheless, it moves forward, and it's exciting to join you tonight. This truly is a signature college event. It's a signature college event for multiple reasons, but primarily because we have the opportunity to gather to discuss important topics to athletic training and the health professions. And probably more important than the topics itself are the impact of those topics. And when I heard Tony remind us or share with us that this was the 10th annual Athletic Training Speaker Series event, I called into some reflection, having the opportunity to be part, I believe, of all of those, but most importantly, the opportunity to reflect on how I feel every year leaving these events with the thoughts that are raised, the questions that are posed to us, and frankly, the challenge we find before ourselves as athletic trainers and as healthcare professionals. The interprofessional nature of the work, the landscape we find ourselves, merits our continued exceptional work to make sure that we're navigating it in the best way possible. I'd like to thank our distinguished speaker this evening. I'm absolutely certain you will guide us in those continued thought-provoking conversations and reflections, as well as our panelists. Thank you to those individuals that made this event possible. Oftentimes I found more work goes into a virtual event than not. Congratulations to our students and the award winners and inductees. And lastly, I'd like to close with a thank you to the Bridgette family, whose constant support and reminding us of Brandy moves all of us forward. Just a short year ago, we were gathering in person, and how things have changed in that year. But thank you for agreeing to join us. On behalf of the Boise College of Health Sciences, welcome, and I look forward to this evening.
Thank you, Tricia. We appreciate your leadership and the advocacy. I reiterate my gratitude to our administrative staff in our department, to our program faculty, to our students, if there's any preceptors on board, our alums, for their continued support of our the event. So speaking of event, now it's time to get moving. So we will, I'm going to introduce Maddie Kavanaugh, the president of the SLU chapter of Iota Alpha, to introduce our keynote speaker.
Thank you, Tony. I'm honored to be able to announce our keynote speaker for this evening, Dr. Kathy Derringer. Kathy is the sole owner of 3 outpatient rehabilitation clinics, D&D Sports Med, in the North Texas area, employing over 45 staff members, including physical therapists, occupational therapists, athletic trainers, and strength and conditioning specialists. Previously, Kathy worked in the collegiate setting for 13 years, secondary school setting for 6 years, and entered the clinical setting 22 years ago. Kathy continues to work with youth sports athletes as part of her outreach practice. Kathy's passion for giving back to the profession has resulted in over 20 years of volunteering for NATA and the Strategic Alliance. In addition to serving on various state, districts, and NATA committees, Kathy served as NATA District 6 Director and Secretary-Treasurer for the NATA and the President of SWATA. Chair of the NATA Clinical and Emerging Practice Athletic Trainers Committee, currently known as COPA, and is the AKD Commissioner. Her visionary approach to the profession resulted in the creation of the Healthcare Reform Work Group and the implementation of the Accountable Care Organization Demonstration Project, currently in process. She is currently the President-elect of the NATA. Without further ado, Kathy Derringer.
Good evening, everyone. I'm Kathy Derringer, President-elect of the NATA. I'm joining you tonight in a recorded presentation because, as many of you have probably heard, there is some unprecedented weather in Dallas-Fort Worth area. We're currently experiencing rolling blackouts. It's such a joy. About every hour or hour and a half, power goes off for anywhere from 15 to 45 minutes. So because of the unpredictability of that, we felt it was best if I recorded my presentation, and then I'll join you live for the panel discussion and any Q&A that you might have after the presentation. So first and foremost, I'm honored to be asked to be the keynote speaker. I have the greatest respect for SLU and your faculty and your students. You're doing incredible work with the future students coming out of your program, as well as how well you are known for interprofessional collaboration and your leadership there. So thank you for honoring me with this invitation. When I was asked originally to speak about value, I have to tell you, it's one of those topics that's near and dear to my heart. I've been talking about it for a very long time because it's that critical, in my opinion, to the future of our profession. So these are some of the things that I think that I plan to go over, as well as just letting you know that I have no conflicts, financial or otherwise, with this material. So as I mentioned, this is a topic that has been very important to me throughout my career. In fact, I gave this presentation in 2017. And when I was asked to do this topic again, I went back to this presentation and I looked back through some of the research I did at the time, especially regarding trends that were occurring in healthcare. One of the sources that I had for my talk back then was PricewaterhouseCoopers. They have a healthcare think tank that looks at healthcare issues at that particular time and makes predictions about what is coming. And so I went back and I found this particular slide and went over it again and then used it as a basis for some of what I'm going to talk about. And I think the topics that they talk about are very pertinent to what we need to talk about today. You'll see a lot of themes throughout the talk today that are identified on this particular slide. But you'll also find a pretty eerie a bullet point there that they talked about in 2017 in regard to infectious diseases, which of course we lived through. So this was what they thought in 2017. Now they do this particular report every couple of years. So I pulled 2019 as well. And you'll see again some of the same themes: technology, big pharma, what's happening with government regulation of healthcare, payers, the Affordable Care Act, what's going on with insured and uninsured individuals, and the cost that patients, that consumers are paying for their healthcare, and the need for transparency regarding all of that. And of course, payment models. So you saw on the last slide how it talked about value-based payment models. And here again, we see it in 2019. Now, because they only do this particular report every 2 years, I was curious as to what was being said in between this report and the 2021 report, which obviously was post-COVID. So I found another think tank that talked a little bit about healthcare trends for 2020. But amazingly, we have the same kinds of issues: out-of-pocket costs, transparency, big pharma, healthcare providers closing because of reimbursement. So again, we're talking about payment models and the social determinants of health and the need to focus on those. So then again, we go to 2021. COVID has hit, and we're talking, oddly enough, about a lot of the same issues. We're talking about the need for digital, the need for technology. And it was so much more of an issue in 2020 because we had to find a way to communicate with our patients when we couldn't be face-to-face. So telehealth became a huge thing for us in healthcare. We had to talk a little bit about public health. And the interesting thing is that the infrastructure of our public health organization is not very good in the United States. It's difficult to get data. And how amazing is that to hear about the United States? We looked at history and the leadership in healthcare. So for example, this recession in 2008, the strong got stronger and the weak got weaker, suggesting that leadership matters. Who is making the decisions? Who's sitting in that chair making the decisions has a huge impact on what happens moving forward. And of course, healthcare reform, our president was a big part of the Obama administration and the Affordable Care Act development when in that administration, and what's going to happen now in terms of healthcare reform and payer models. And then of course, the impact of mental health and what's going on because of COVID and how that is going to impact us moving forward. So what does all of this mean? What what matters in terms of healthcare, from my perspective, first is analytics. We have got to be driven by data, but specifically, visionary data should be driving our decisions. As I mentioned, leaders have got to use that data and be visionary and very strategic in their planning. We have to look at social determinants of health. What is creating, where is our population health? And what is creating issues within populations who, especially our populations of color? And how is the lack of healthcare or the need for healthcare reform impacting them the most? And then the need for collaboration and working together. Interprofessional communication is oh so important. And we're finally starting to see that as we see this particular statistic where healthcare executives either are already doing it or are planning to reach out to other healthcare providers and payers in terms of a response to the pandemic. So collaboration is key right now. And speaking of collaboration, I'm sure you saw this that was released last week. The NATA and the APTA have been communicating for the last few years. And this particular document that was released, the joint principles that deals with patient care and what constitutes us as a healthcare provider and the APTA as healthcare providers. And it's driven by Practice Act and education and not by setting. This is a huge accomplishment for both organizations, and we're so very proud of being able to release this document. And what I'm excited about is what's yet to come. We've come a long way in the last few years, and I'm confident that the collaboration will continue. And isn't that what interprofessional communication is indeed all about? And then the final thing that matters in all of these trends is value-based healthcare. Value-based healthcare is here to stay. And our need as a profession to not only recognize that, but to embrace it and take advantage of opportunities that it presents to us is very important. Other healthcare professionals have already embraced value-based healthcare, value-based payer models. And in a way, we have already been doing this, as we'll talk about here in a few minutes. But now it's about really looking at where we fit into this. And it's not like we haven't been talking about it. The February issue of the NATA News is all about my favorite topic, value, and how to show our value, how to collect data to prove our value, and how to use that moving forward. And why is this important? Well, as we look at what happened in 2020, value is a big part of that. COVID hit, and we had graduating students that couldn't take the BOC and couldn't enter the workforce. We lost athletic trainers to COVID. A lot of athletic trainers lost their family and friends, as did many people around the world. And hundreds of athletic trainers lost their jobs because their employer did not value them as a healthcare provider. But at the same time, we had employers who did value athletic trainers. And they looked at our skill set and they repurposed us. They used us for screening and for testing and for tracing, and now for vaccine administration. These employers could have done what other employers had done and just furloughed or laid off. But no, these employers saw our value. So the question is, what's the difference between the employers who saw our value and those who didn't? And in that answer lies the opportunities that are available to us as a profession. We had so many athletic trainers in the collegiate and in the high school and the professional ranks, as well as in all of those other settings. We had to become infectious disease experts overnight. We had to learn how to prevent the transmission of COVID, how to test for it, how to trace it, and how to do everything that we had to do to protect our staffs, our patients, our colleagues. That's what we did. That's who everybody turned to in order to make that happen. And in order to do that, we collaborated with so many different types of healthcare professionals and the NCAA and the NFHS, and our credibility rose tremendously during the COVID-19, especially in those early days. And here's why. We had to pivot. We had to look at what was going on, and we had to change everything that we thought about what we were doing and do what we needed to do to take care of our patients. Okay, so for those of you who are younger and don't get this meme, here's one that'll make more sense for you. We did what we had to do to help, to take care of our patients. See, 2020 to me is represented by the O's, 2 different O's that we can choose from how we responded. We could look at it as obstacles, or we could look at it as opportunities. My preference is to look at it as, how does this present opportunities for us? Not that ITs losing jobs should be ever thought of as an opportunity, but how we respond to it can be. This is one of my favorite. Maya Angelou is one of my favorite, and this quote in particular is one of my go-tos. Of course, when I read this, I always want to do the first. I want to change it. But there have been a few times where I have had to change my attitude. I want to find a way to change, because I think with change comes growth. And if we're standing still, we're falling behind. So we have to talk about change, and we have to embrace change in everything that we do. Many of you know that my career started as a collegiate athletic trainer. I thought I was going to be in the collegiate setting for years. I was there for about 15 years, thought that was my future. That was my plan from day one. But an opportunity presented itself, and I had to change as a part of it. I had to learn about outpatient rehabilitation. I had to change my mindset. And so too has our profession changed. We have gone from a profession that was based in athletics only. We were support staff. We got very little recognition, very little thank you, and we were behind the scenes. And we have changed so much in the last 60, 70 years to become a bona fide healthcare provider who is an expert, a clinical specialist in outpatient musculoskeletal and the treatment of athletes, both in the athletic arena and outside, warrior athletes, industrial athletes, whatever you want to call them, and embracing that healthcare status, even in the areas of physiology and recovery. That's how much we've changed. We've also changed in terms of where we've practiced. So our foundational settings of secondary school and collegiate and professional have changed into different areas like public safety, where a patient population needed our services. And there was an athletic trainer who said, hey, I can take care of you. And we took our skill set to that different patient population, the change that we've seen. In 1950, when the NATA was established, we were 100% men and mostly white men. And today we're over 55% women. And in June, for the first time ever in the history of the NATA, there will be more women sitting in the boardroom than men. So those demographic changes in the NATA as well. Years ago, there were 2 ways to be eligible to sit for the NATA exam: going to a bachelor's curriculum program or an apprenticeship program. That quickly changed, and it was only an undergraduate curriculum program. And of course, now you know that we're transitioning to a master's entry-level degree that is filled with immersive experiences where we are side by side with other healthcare providers, like being in the OR with the surgeon. Fun fact, that's my knee. That is split wide open right there. We've seen changes in legislative issues. I can remember the first Hit the Hill when we went to Washington, D.C., and we spent the majority of our time explaining to staffers and our congressional leaders what an athletic trainer was. Because nobody knew us. Nobody believed in us. Nobody trusted us on DC. Well, fast forward now, and we have passed the Sports Medicine Licensure Clarity Act. And now not only do our congressional leaders know who we are and what we do, they're inviting us to DC to testify in front of Congress, to be a part of very important meetings to advance youth sports safety and our needs as a professional organization and as a profession. And of course, as I've mentioned, our settings have changed. And now we have athletic trainers who are in the performing arts and the industrial setting and the physician practice and public safety and the military, and the list goes on. And I think there are more that we haven't even identified yet, because that's how much our profession is changing. Someone saw a need, some athletic trainer saw a need in a patient population where athletic trainers hadn't gone before, and said, I can take care of those patients. I have that skill set. And here we are. And of course, a lot has happened in the last year as well in terms of racial injustice and the need, the recognition of what our profession needs to do to address the social determinants of health and to address the lack of diversity among the leadership and among even the membership of our organization. And what can we do to change that? But of course, all of these things that I've talked about that are opportunities are just that, opportunities. We can identify them, but now what do we do? Identifying them in and of themselves are not enough. We have to take it to that next step. And in order to do that, we have to identify what we're trying to accomplish. I've asked this question for many years. What do we as athletic trainers need? Do we need to focus only on athletics? We have to answer that question first. And some of the answers that I've gotten is, I want credibility for my profession. I want work-life balance, and I want a salary that I deserve. And I would submit that all of these are merged together. If we can get one, we will likely get the rest. But there are some things that we have to think about as a healthcare provider to make that happen. In order to turn the page, we can move forward as a profession, but we have to figure out what it is that we don't know in order to be a part of healthcare. We have to start focusing on the nuances of healthcare: quality improvement, population health, consumer-driven healthcare, and yes, value-based payer models. Though that's where opportunity lies for us. And it has to become a priority because it's a priority in healthcare. And if we can take all of our energy and understand those concepts of healthcare and merge them together, there's no stopping us. We will continue to move forward. So I like to ask this question because it's brought up to me before that we just need reimbursement. Do we need reimbursement? Is it the answer? Well, I think it depends on what the question is. If the question is, how do we accomplish all those things? I think reimbursement is a key part of that. And here's why I think that. The current reimbursement model is fee for service, meaning the patient comes in to see me and I do 15 minutes of therapeutic exercise. I charge for 15 minutes of therapeutic exercise, and that's what I get paid for. But reality is that fee for service is going away. It's in the past, and what's moving forward is value-based payer models. So how do we fit into that? Well, we know our worth. Our worth is the monetary cost of our service. So it's our salaries, or it's what we charge for something. Value, on the other hand, is the perceived worth of something, and that can change. So my worth as an athletic trainer actually is probably pretty stationary. but my value goes up based on what I'm doing. If I'm taping an ankle versus spine boarding a C-spine injured athlete, my value changes tremendously. We have always been about, in our profession, about value, about patient-centered care. Now we have to understand value-based healthcare and the opportunities it presents. The opportunity to be a part of a healthcare team where our recognition as being reimbursable may not matter. We're a part of a value-based payment model, accountable care organizations, medical home, those bundled payments, those types of payment models we can be a part of. But we have to understand worth, value, and our return on investment to make that happen. Because understanding value is where our profession is going. And we have got to go along if we want to be a part of it. So let's talk about a healthcare definition of value. Quality, where quality is patient outcomes, their safety, their experiences, divided by payment, the cost of that treatment, the cost of to the patient. Do they have a deductible? Do they have a copay? The cost of providing that provider. What is the salary of that provider? What is the cost for the patient to get to me? All of that goes into it. I submit to you that because of our skill set, we provide just as much, if not more value, especially in a rehabilitative setting, than many other healthcare providers. We are definitely in the ball game. It's just a matter of showing it. Sadly, however, many providers' value is based on their recognition as a CMS provider. And we had that up until 2003, where a ruling took it away and gave it to the PTs and the OTs. So why is this important? A lot of athletic trainers have said to me, Kathy, I don't want to treat Medicare patients. I want to treat my athletes in a high school. That's okay. But see, here's the thing. If we're a CMS recognized provider, with that comes the recognition from all of those other insurance payers, because they go as Medicare goes. Medicare drives the bus on those issues. Medicare leads the way. So even if you don't want to see Medicare patients, even if you don't want to charge for your services and get reimbursed, that's okay. You don't have to. But if I want to, or if Judy Smith, athletic trainer, wants to, they should be able to. And that's what going after CMS recognition and reimbursement across the country is really all about. Now, I told you about what happened in 2003, and since then we have been working behind the scenes, doing some regulatory activity, creating a political footprint, as you saw. And there will come a time where we go back to Congress and say, hey, we want to be recognized by Medicare. We're not quite there yet, but we will be soon. But it's also going to take us thinking outside of our own box and figuring out who we are, what we're doing, and what we want to do. Are we athletic staff or healthcare providers? Can we be both and have medical decision-making autonomy? I think we can, but it's going to take all of us working together in the same direction to make that happen. And if we're able to do that, it is my belief that being a revenue-generating clinician will create all of those things that we've been asking for: better salaries, credibility, and work-life balance. Because revenue-generating providers get paid more. With that comes better work-life balance, comes more credibility. All of those things come together. It's simple economics. Even the secondary school athletic trainer will appreciate a higher salary because of supply and demand. It's not going to happen overnight, but it will happen. So these are things that I want to see happen. I think we can see happen. I want to work toward. What are things that have already happened? What's already worked? We have improved our medical decision-making autonomy, especially in the collegiate setting, especially in the professional setting, and now moving forward in the high school setting and throughout all of our other settings. Using post-professional education and even our incredible educational process to create a clinical specialist. That is happening. Creating more and more opportunities for secondary school athletic trainers that are being employed by the secondary schools. And while the model of being hired by a hospital or a clinic seems like a great idea, we saw what happened during the pandemic to those particular models. We would like to see athletic trainers hired by the school district. And the mantra of you can't afford to have athletics without an athletic trainer has got to become the prevailing thought across the country. And of course, we've already talked about the emerging settings and our presence there and in youth sports, and also about branding. Who are we and what we do and how people look at us is very important. And I believe that with all of these things, we can do anything. We can do absolutely anything. But it starts with some things that we have to do a little better at. One of those is documentation. You know, there's some studies out there that don't reflect very well of our ability to document what we're doing with patient care. That has got to get better, as well as our collection of patient outcomes data. We can't move forward in third-party reimbursement, in CMS recognition, in anything that will increase our credibility until we, as athletic trainers, learn how to collect patient outcomes data. Every other healthcare specialist does it, and we have to be able to do that too. We have to embrace that as a profession, and you will see more and more of that. We're doing some of it in a few projects, one of which the ACO demonstration project that's currently going on. We have placed an athletic trainer in a rehabilitative setting in an accountable care organization for the sole purpose of collecting outcomes data. We can do it. We will find a way to do it, and we must find a way to do it. And it takes each and every one of us to get on that bus and continue to drive it forward. And what other opportunities are out there? Athletic trainers in emergency departments, athletic trainers in primary care physician offices. You know, primary care physicians will tell you that their least comfortable area is typically musculoskeletal. It just makes sense for us to be there. Accountable care organizations, we talked about. CMS, I've talked about. And then increasing our ability to be a clinical specialist through post-professional education for those athletic trainers who want to do that. It's a part of the medical model. And then what others are there that I haven't talked about? Ideas that you have, ideas that others have, as we look forward to other opportunities that are happening. And then the collaboration, reaching out even more than we've already done to the NCAA, to the National Federation of High Schools, to the National Association of Healthcare Professionals, to physician groups, to administrators in hospitals and in clinics, and really communicating the value that an athletic trainer brings. You know, during that pandemic, when they were responding to those emergencies, those athletic trainers should have been in the room. Who's better at emergency response? Who's better at emergency planning than athletic trainers? We do the best EAPs of anybody. So taking advantage of that now and talking to these influential decision makers to get us into the room will go an awful long way with increasing our value and credibility among healthcare. And isn't that what it's all about? You know, when I started this talk, I talked about trends that were happening in healthcare. And some of those trends include moving more to a health and wellness so patients can lower their healthcare costs. That's us. Prevention, fall prevention programs, fitness programs, performance enhancement. That's all us. Collaboration includes talking to those hospitals and those clinics and getting an athletic trainer in the room and making sure that people understand the value that we bring to our patients. And we have got to lead that effort, each and every one of us, by learning how to collect data, show our value, and own that impact that we have on our patients. And leading with value-based healthcare is what it's all about. We have an incredibly passionate, innovative, forward-thinking population of ATs. So let's get busy. Let's get busy thinking more about value, thinking about how you can show your value every single day in everything that you're doing. Because it's all about standing out. It's standing out from those other healthcare providers. It's standing out from that athletic staff and letting people know what we bring to the table and how our employers really need to have us there for that. So I have ideas on how to get there, but I know there are other ideas out there, and I welcome each and every one of them. I want to solve every problem, but hey, I'm only president for 3 years, and I won't be able to solve all of them, but I want to get to the big ones. So if you have ideas, I encourage you to reach out to me and tell me what those are, because we're all in this together. We can move our profession forward in healthcare. We can be a force in healthcare, but we have to do it together, each and every one of us. I, again, thank you for this time today. I appreciate being invited. I am honored to be invited. And now I look forward to our continued conversation.
Thank you, Kathy. We greatly appreciate your presentation.
So what I'm going to do now is introduce our Iota Alpha officers that are going to introduce our panel, and we will get going. So Maddie, do you want us to get started?
I would like to welcome Dr. Kitty Newsham as our moderator for the panel today. She is an associate professor in the Department of Physical Therapy and Athletic Training at St. Louis University. She has had more than 20 years of clinical experience in athletic training in collegiate, high school, and industrial settings. She has an extensive history to service in the profession.
I would like to introduce Katie Smith. Katie has been an athletic trainer for nearly 10 years and has spent time in the pediatric, high school, collegiate, professional, and hospital settings throughout her career. She completed her undergrad degree at Southeast Missouri State University and her master's in education from Lindenwood University. She's the Midwest Regional Manager for Sports Care USA, a national healthcare company dedicated to building and managing hospital-based sports medicine service lines. Locally, she manages SSM Health Sports Medicine, which includes 12 full-time athletic trainers, 2 triage lines, an outreach education program, as well as high school and college partnerships.
And I would like to reintroduce Father Rogier. Michael Rogier is an assistant professor of health management and policy at St. Louis University. Rogier received his bachelor's in chemistry from SLU in 2003, and upon graduation, he entered the Jesuits, an order of Roman Catholic priests. He has since earned graduate degrees in philosophy from the University of Toronto, in international health from Johns Hopkins University, and in moral theology from Boston College. He was ordained in 2014, and in 2018, he earned his PhD in health management and policy from the University of Michigan. Rogier serves on the board of directors of SSM Health Corporation and on the board of trustees of Marquette University.
Well, thank you for those introductions. We are happy to welcome this panel. And what I would like to start with is to see if, just to hear Katie and Father Rogier, if you would share your initial reactions to the presentation that we just heard.
Yeah, absolutely. You know, I think it's a great topic because it's one that we talk about a lot. Is really quantifying value is something that myself and really the company that I represent talks a lot about. And it's really been something that I've spent sort of the last 5 years of my career starting to understand. And I really loved the point specifically about understanding data and learning to utilize data. Personally, I think, you know, when I graduated, I think I had a clinical skill set, and I think that was incredibly important. But I think much of what I had to learn after that was how I wanted to use my clinical skill set, but then specifically how to understand what my personal value was, but then also to understand how that value could be used and where I was employed and in multiple different settings. I think that's something that is a learned skill, and that does take time. And so I think for our students who are upon graduation or will be graduating in the next several years, I think that's something to really think about. And I think Kathy just made a really great point to that of really getting their wheels thinking about that when they're in their clinical settings right now, because I think that's something we just don't think about as students.
Yeah, thank you. And I just really appreciated a lot of the observations that Kathy made during the presentation. I took lots of notes, looking forward to the conversation. A couple questions that emerged for me as we move forward is value to whom? So I think you can shape your value proposition for providers differently than you can for patients, differently than you can for payers. And so the narrative or the case is going to be made in a very different way for each one of those. And the other thing that I think she brought up in a lot of different ways was this kind of quadruple aim of healthcare that we're all after right now: lower cost, higher quality or patient experience, better population health or health equity, distribution of health outcomes across the population, and then enhanced provider experience as well. And so I think as kind of an interloper in this conversation, somebody not trained in your profession, I see a lot of value propositions. My kind of case to you as an outsider would be choosing which one of these strategies to prioritize, I think is going to be really important as a profession, because she brought up a lot of different ideas, and I don't think we can be all things to all people. I look forward to hearing which one of these people think ought to be the priority strategies.
Okay, great. Thank you both. And Kathy, thank you for that presentation. I was present at your D5 lecture in 2017, and yes, this continues to be an issue for all of us as we look forward. So, you know, I looked at this, you know, as I'm thinking, and I was listening to these and looking at the social determinants of health, and we deal with underinsured and uninsured people in this community. And across the country for sure. And when I think of the models that we have, I see sports medicine, but that is medicine. And for those who are engaged in the practice of athletic training at the intercollegiate, at the secondary school level, we know that we deal with far more than musculoskeletal injuries and emergencies. We deal with colds and flus and rashes and diabetes and asthma. And so if we look at social determinants of health and how athletic trainers can influence that and how that blends in with the value model, I would just like to hear some of your thoughts on that. And I would open that to all of the panelists there.
That's a great question, Kitty. So I'm going to leave my camera off because all I have is candles around me right now. So, and I can't imagine what that would look like. So I'm going to leave my camera off. What a great question. And I think a lot of the answer to that question starts with us even recognizing that there are issues. There are issues for our patients who are people of color. There are issues if our patients are in the LGBTQ+ community. There are issues if we have patients of different religions and how they celebrate their religion. And for so long, I know coming up through my educational matriculation, those things were not in the forefront of my clinical education. And so even recognizing that there are social determinants of health that for our athletes and or patients I think is a very important first step that for many, many years we didn't get involved or get involved with. And more so even now, as you mentioned, Kitty, we do so much more than musculoskeletal. And the mental health aspect right now of what we're seeing, especially in the collegiate and the high school level, many of my collegiate colleagues have talked about how difficult it is to deal with the mental health aspect of collegiate athletics. So all of those things together makes us so much more of a diverse clinician, but it makes us a better clinician as long as we're aware that we have to recognize those differences in our patients.
I think that's a really good point, and I think it's something that I'm grateful to see now in a lot of our young athletic trainers, though, because I think they are much more aware of that. I think that has changed culturally over time. So I think that's been a great thing to see. You know, I manage a staff of almost 15 athletic trainers, and it's interesting to see sort of how that has evolved over time, but also just not being afraid to involve things like training in that. I mean, we implemented that in the last several years of training our athletic trainers to help manage that some of those situations, but also help them identify that some of those social inequalities do exist, and that it's okay to understand that they exist and to identify that. So that they can manage those situations appropriately. But I think one of the things that we try to focus on is equipping our athletic trainers with the skills to help in those situations. Because I think a lot of athletic trainers, once they identify that there is a need, a lot of times they can be that gatekeeper, or they can be that person to provide that next step. But if they don't have access to the next step, it becomes a stopping point. And I think that is one of the challenges that we face in all parts of healthcare, and that it's not specific to sports medicine, is that healthcare is very confusing. It's incredibly difficult to navigate. And, you know, athletic trainers know how to navigate the world that they're in often. But one of the challenges is if they aren't exposed to beyond just that within healthcare, they don't have the access point to get further than that. But if given the tools to have this access point within healthcare, they can be this navigation tool to these patients in these more challenging patient populations, or people who don't have great access to healthcare. You know, we talk about all the time, one of the number one issues in healthcare is just an access to a primary care physician on a regular basis. That is one of the most basic fundamental aspects of healthcare that in a lot of our society we struggle with. That athletic trainers really have the ability to help us with things like that if they have the tools. And I think that's a really key part of that, is equipping those athletic trainers with those skills and then continuing to equip them, because we put our athletic trainers on an island sometimes and say, okay, you're trained and you're ready to go do it. But it's those continued resources that are really going to help them succeed, but to help their patients succeed, because that's who needs that assistance. And that's where we can help those patients thrive in those environments.
I find the conversation around social determinants of health both exciting and honestly a little challenging, and that particularly emerges from the idea that a lot of the studies that we are seeing in terms of what we hope had massive payoffs in terms of cost savings are not showing. A lot of the value-based reimbursement models that we thought were going to be quite promising just haven't been. So I think one of the promising pieces of social determinants of health for athletic training, I heard Kathy reference, probably a preference for working with younger folks. I don't know if that's true within the athletic training community, but the challenge with social determinants is that those under the age of 35 only constitute 21% of all medical spending in this country. And so if you're really going to do some cost-saving measures around social determinants of health, it's not going to come from the youth. But the great thing about social determinants is if you provide better food security, better housing, better transportation, better ways of recreating, less violence, and you can capture that cost savings with the older population, that also benefits the younger population. So it's building these broad coalitions of healthcare providers, and all patient demographics end up benefiting from social determinants. And that's a short-term win. The long-term win, I think, for people who might work with youth more, is the knowledge that we're gaining from adverse childhood experiences that can also be driven by social determinants of health. We might not see the negative health outcomes for decades, but if we can solve that problem, make the case in terms of a social impact model, I think there's some really creative empirical work to be done there.
Excuse me, I have a question from the audience. Christine Lauber has asked a question. As a part of a large healthcare system employing over 60 athletic trainers at 25 plus area high schools and middle schools, gathering patient outcome data is critical. However, how do ATs compare their outcomes to PTs, OTs? There's no wide, comprehensive normative data, outcome data out there. Kathy mentioned visionary data in her presentation. Other than patient outcomes, what would be examples of this kind of data?
Well, I hear your question, Christine, about comparing data to PTs and OTs, and that's really not where I was going. My concern is that as a profession, we haven't done a good job of collecting patient outcomes data, period. We know that we're good at what we do, but we don't have the evidence to prove that. And until we have that evidence, moving forward in healthcare and doing some of these other things that we want to do, we're always asked that question. Can you show me some empirical proof that you're good at what you do? And we know that we are, but we need that proof in order to do that. And when I say visionary data, I'm thinking about moving us forward in healthcare means patient outcomes data has got to be a part of that first step so that we can do some of the things that we want to do as a profession.
I would agree with that. And I think it's also about looking at year-over-year data is also important because you're looking at growth strategies as well. You're not necessarily just looking at comparative data is hard when you're comparing with another profession because it always turns into apples and oranges very quickly, I think. I think when you're looking over true year-over-year data, when comparing amongst yourself, you tend to see positive data when you look at patient outcomes for ATs. We use a lot of internal hospital data ourselves. Ultimately, patient referrals into a health system do benefit us. We look at it in a simplistic model of we have a completely separate team of athletic trainers who don't deal with patient care with our schools, that they manage all of the patient referrals for our team. And so they're basically their full-time job is to manage patients that come from sort of our outreach team of athletic trainers. That way you don't have any stark violations or any sort of concern that that's going to affect care. Their job is just to say, hey, this patient needs to be evaluated for something. Can you manage what the next right step is? But then we have a separate team of athletic trainers that manage that. That data we do hold on to, where it comes from, how those relationships were built. Do they trend upward over time? And fiscally, how does that benefit the health system? More than anything, that does help offset costs, which does benefit the overall model of having athletic trainers at the school. It does make a difference for the health system. Ultimately, most health systems that you talk to from an administrative perspective, their goal is ultimately just to break even. When you look at truly athletic training models, the goal is not to benefit from a fiscal perspective on just the athletic trainers alone. But the relationships that are built that you're talking about are 10, 15, 20 years down the line are substantial. And that's what they're looking to build. I think you also have to understand the market that you are. I think that it's a very old school thought to say that athletic training is the same in every market. St. Louis is a prime example of a market that is very saturated for healthcare. And so you have to understand that that very much plays into how the market of sports medicine works in a town like this. In towns where there's one hospital in town, that's going to work fiscally very different because the demand for that is high with a lot lower competition. And so I think you have to look at those pieces of that puzzle to understand what pieces of the data your hospital system are going to find important. Kind of like Father told us at the beginning, what are we looking at and what's valuable? Value is different to lots of different people. I think that was one of the hardest things I learned is I was looking at lots of data and I went to an administrator and they were like, well, that's great, but we don't care about any of that data. That doesn't mean anything to you. Learn that a lot of times before you're like, okay, well, I looked at all the wrong pieces of data. Data is great until you know what you're looking at, right? It's just like we joke all the time now. now, 7 years in, of gross revenue is great on the hospital side, but it means nothing because you don't get gross revenue. So that doesn't mean anything. I think it's understanding those pieces of that to understand what your health system values as far as that quote unquote data that's valuable to them.
And I'm gonna put on my health system board member hat for just a moment, because in addition to obsessing over patient outcome data, we obsess over the consumer-centered nature of healthcare, so the patient experience as a really important part of the patient outcome. So if you can show that patients are more engaged because of your presence, especially over the long term, more committed to a particular healthcare provider, that is gold right now in healthcare. And the other big thing that we obsess over is burnout of our healthcare providers. And so if you can show if you can provide a piece of data that say, when an AT is embedded in a healthcare team, everybody in the team actually benefits. Like you reduce burnout from all the other healthcare providers by being embedded in that. That is also golden data that you could bring and make a case for healthcare leadership.
Absolutely.
I think those are all really interesting points in this whole big picture of things. And when we look at, Kathy, you made this reference to the medical home, and I look at the athletic training room as the original medical home, where the athletic trainer took care of this patient and knew the patient's family and knew what their situation was and understood which healthcare providers needed to be contacted to provide the appropriate care for that individual. And we've been doing that from our inception. And how can we take that and move it to a bigger model and say, look, we're good at this. We play on the team with everybody else. And we know how to bring out the best. We are the point guard of the healthcare medical home. That's the way that I see it. And as far as some of the questions for collecting data, for collecting the outcomes, as yes, here's another opportunity for interdisciplinary. Maybe it's not interprofessional. Maybe it's within the profession, but we have people who are really good at collecting and interpreting this data that need to be involved in the team to bring it all together. And that's breaking down the silos between academics and researchers and clinicians and administrators and seeing that there's really room for us under this big tent.
And Kitty, I would just make it clear. So my training is in health services research.
Sure.
And so there are a lot of HSR folks out there who have expertise in exactly this area, who are, very excited to partner with clinicians, because we don't have the clinical expertise to do a lot of this stuff. And most clinicians in their training are never given the skills for the kind of methodological things that HSR folks do have. So just a plea for partnerships wherever you are.
Sure. Yes, and I we'll talk.
Yeah, I was just going to say the same thing. We're going to have a conversation.
I hate to steal your thunder on that one.
Nope.
We have another question from Alan Friedman. The approach to collect outcomes data requires a paradigm shift in the research focus. How do we place the emphasis on that approach and still do clinical research?
I think we just add that layer to our data collection, and we pull people like Michael in on that one and expand our tent a little bit.
Great. I think a lot of that comes back to proper documentation, though. I think that we see a lot. I think also if we get back down to the basics of documenting appropriately and doing just simplistic data collection well, then you have brainiacs like Michael who can go and comb through that data and help you kind of find what's important. We always tell our ATs now, and we've gotten better at it with time, collect, collect, collect. We can look through it later, but collect, collect, collect. You can't over collect information. You can't over document information. So we would rather you collect everything you have and then we don't use it. But much of that is coming up with a system that works and that's effective, I think, that's half the battle. And I think that's the shift though, when we talk about really being healthcare professionals and not saying that we're stuck in that athletics mindset of you have to document the work that you do, and finding a appropriate HIPAA compliant system that you work in every day and that every bit of what you do goes into it, because that's how you track things well. The old, and I did it when I was in school, you just do work and it's not written down places, and some things are documented, some things aren't, that doesn't work, unfortunately. And we can't show our value because a lot of that's lost and there's just no proof of it, unfortunately. And so that part of healthcare is really important. And I think for myself, at least working on the hospital side, it helped me see that a lot better, and utilize that sort of skill set that the hospital provides. They're very much simplistic, but yet complicated in that way of thinking from the hospital mindset. But transitioning some of that thought process though into the athletic training room is really helpful, because you can use that same thought process and then use people at the hospital to sit and say, okay, well, what do I do with this? How do I turn this into something that can be valuable? But you gotta have a system that you can collect it and collect it well, I think.
And I would say this kind of good data collection is not only going to benefit the profession, which of course it will. I think another thing that Kathy really emphasized was the benefiting of the community. So without that data, we don't know where are there deficits. The kind of data that we have in electronic health records have kind of raised the light of kind of systemic racism within healthcare professions that we knew was there, but now we actually have data to show how does it manifest itself and how do we respond. I think the opportunity that's being spoken of right now, of course, is great for the profession, great for the individual patients, but also really good for us as a community to recognize where are the opportunities and where are the kind of deficits.
Yeah, absolutely. No doubt. That's a great point.
So, listening, of course, to your presentation, Kathy, and you talked about, are we stuck between, do we have a choice? Is this like we're in athletics or we're in other settings? And, it's kind of like that mobile phone commercial, that it doesn't have to be or, but it could be and so athletic training can find themselves in a lot of arenas. And, if other healthcare professionals have those choices as far as where they land, why not with ATs? And it brought me into the recent issue, the current issue of the NATA News. And Tori Lindley, the current president of the NATA, put some things out there. And he talked about setting goals and setting boundaries and telling your story. But he also said, the grass isn't always greener, and that sometimes you're sitting in an employment situation and you see what you think someone else has, and you want to jump at that. And he talked about maybe not leaving your job, but can you make your job better? Can you fix the things you don't like and emphasize the things you do like? And I go back to the Hall of Fame induction when our friend from Chicago, the name is escaping me right now, but he said, yeah, my first job sucked, and then I made it better, and I stayed there for 32 years. So that was all bubbling around in my head. And I thought, okay, listening to your talk, and you talk about obstacles and opportunities. And I would look at this as sometimes it's landmines and landing spots. And so do you have thoughts about when someone is faced with an opportunity, what would they look for to see if that is a landing spot or a landmine?
Well, let me start with, I think you're talking about Brian Robinson, right?
Yes, I am. I loved that. I loved his
yes.
talk, by the way.
And the interesting story about Brian was a high school athletic trainer for years, who didn't collect data, didn't document, and he was challenged to do that. And once he started doing it and collecting the data and using, he basically did the secondary school value model before it existed and collected all of that information about what he was doing. And was struggling with, just as you say, my job, I didn't like it. I was thinking about leaving. And he decided to have a paradigm shift and start to collect data and start to really show his value in different ways. And because he was able to do that, because he had that data to back up what he was doing, he was able to hire more staff. He was able to increase his budget. He was able to increase his work-life balance because of data. That's how powerful data it was for him. So he's collecting how many patients he was seeing and how many hours he was working. And because he had it in black and white, his administrators had to pay more attention to it. So I think to take that then to your question, Kitty, and when is it a landmine and when is it a landing spot? I think it's a landmine when you're losing yourself in it, when your mental health, when your physical health is suffering, and you've tried to make the changes that you need to make to improve your conditions, and you're beating your head against a wall. If you're collecting that data and you're bringing all of that information to your administrators, and you're still saying, and you're still hearing, yeah, so what? Go work another 60 hours next week. Then to me, that's a landmine, because it's not, you've tried to make it better and it's not getting better. Landing spot can be, though, the example of Brian. He dug in, he did the things that he had to do to prove his value to his administrators. And by the time he left that program in such a great position for the people who came after him. And they had work-life balance. They weren't working 60 and 70-hour weeks. They were working a decent work week. They were getting paid well. And all because of little changes that his administrators were willing to do. So I think it's the balance between, are you collecting the data and doing the things that you should be doing to try and improve your situation, and is your head being beaten against a wall, or are you sitting back and waiting for people to look at you and go, oh, you work really hard, let me make your life better? Because guess what, that person doesn't exist. You've got to make your life better by doing all of those different things.
And I'm wearing a couple different hats. I'm going to put on my priest hat for just a moment, because this idea of landmine landing pad seems like a very kind of vocational question to me. And for me, it's often a matter of, am I running towards something or am I running away from something? And if you feel like you're running away from something, it's more likely to be a landmine that you encounter, because you're trying to escape. And that's a very different way of moving through the world than seeing possibility and promise and opportunity and wanting to move towards something. And so if as individuals or as a profession, you see, oh my gosh, this is what awaits us. This is the actual fulfillment of our gifts. Then I have to believe that that's likely a landing pad.
Yeah, I would agree with that as well. And I tell a lot of employees this, is that I think our positions have to mold to us and we have to mold to them to a certain degree. I think that there's mobility in almost any position, because I think that they adapt to every personality and every natural gift that we have, because I think that's how we become good at our positions. And that's always how I try to grow my own team, is that it should differ a little bit based on who we're talking about. But I think that certain environments foster people really well and certain environments don't. And I think that ATs have to look upon themselves to know if it's an environment that they know that they can be willing to grow into something that they want, or if it's not. Because I think, unfortunately, we stay in jobs just because it's a job and it's fine, but it's not necessarily full of things that we want. And certainly, you know, I think sometimes, especially right out of school, a lot of first jobs are those things, and that's okay because we don't know what we want, right? Like we just graduated, we haven't had enough maybe trial and errors and maybe enough errors to know that those weren't things that we wanted, because that's how we learn. And I think those are always like great, even, you know, like interview questions of why did you leave a job? I just didn't like it. And I learned that I didn't like it. Oh, that's a good answer in my mind. That's how we learn that how else would you know that you don't like it? So I think that's a lot of it though. But there's a lot of jobs that you can foster what you're naturally good at, but you have to be willing to grow and develop it further than that and make it into something that you really can enjoy, and that it can be better than that. I think that's going to take time. But I think it has to match what we want. And I think sometimes there's a lot of internal thought to figure out what it is that we really want out of those positions, not just the positions that's just in front of us and available. I think they don't always have to equal. And I think that's okay that they don't always equal.
Actually, that's a great segue into one of the last of the questions. Allie asked about how do you, as a young athletic trainer, how do you look forward to having some work-life balance, especially around your family and other types of things outside of work? Can anyone answer that?
Sure. Well, I have a 1 and a 3-year-old, so I don't know that I have the work-life balance thing quite figured out yet. I'm surprised you haven't heard them. It was bedtime when we started this, so I'm sorry in advance if anyone heard me screaming. My husband is saintfully putting but he's trying. I think it's all a balance. You know, I think for myself, I really value that my kids see me work, and that's really important for me. I transitioned to a position, you know, 7 years ago before I was married or had kids, that certainly had nights and weekends and was very busy. And I certainly still work some nights and weekends. But I was able over the last 5 years to transition to a job that had flexibility, that some of my work I could be at home doing on nights and weekends. That was really important for me because my kids were little. My husband is a college lacrosse coach, so he's gone a lot. And I wanted the ability for one of us to be home. So that was important for me. You know, we met at a college. So he was a college coach. I was a college athletic trainer. We got married and looked at each other and said, well, this obviously doesn't make sense long-term. So that's not realistic, right? Well, we at some point probably have to go home and probably have children in the whole 9 yards. So I had to make a career change. I'm so glad I did. I love what I do now way more than when I was a college athletic trainer. And I think I had to find that career path. I think, but for me, it was finding the balance. I like to go to work. I like to be, no offense to mention, I like to be away from my children and have my other passions so I can enjoy being at home when I'm at home, because I have other passions outside of home. And so that's something that I had to grow into. I think athletic training can be really challenging because of a lot of the hours that we do work. But I also think it can be a really great environment because it's a very family environment. And I think that's the part that we love. My team jokes that, I mean, there's kids on like in or on every Zoom meeting that we have because there's so many kids between everyone. And that's something that's encouraged. And so I think what I love to see now that's changed even from when I probably first graduated is an encouragement of the balance and of family. And I think that's what COVID's done too, is, you know, we hear all the time now is like people in the background and are like, oh, but I want to see your kids. And I love that. I love that that's an encouragement. And I love that if my staff were to call me at 8:30 at night and hear kids in the background, they know that I work, but I'm also a mom. I want them to know that because that's a part of me. And so I think that's an important balance of that. I don't know if that necessarily answers the question, but I think it's kind of finding wherever that niche is to kind of feel like you get your piece of home, but you also get to do the work part, which may differ for people. And I think you have to kind of figure out what that balance for you and for your spouse too. Like I said, I think it'd be different if my husband worked 9 to 5 Monday through Friday, but you know, he doesn't. So we had to kind of find our own schedule.
That's a great point, Katie. I think it's not, there is no one answer to that question for everyone. You have to figure that out for yourself. This is a difficult question for me to ask because I'm not a young athletic trainer anymore. But there was a point in time where I had to ask myself if the hours that I was putting in and the work that I was doing, is this really what I want to continue to do? Or do I look for another avenue? The greatest tragedy in my mind is when the answer is for that athletic trainer to leave the profession, because we all know that this is an incredible profession and there are other opportunities that are out there, other settings, other jobs that you can find that work-life balance. It may just take a little searching and a little determination to help make that happen. I made that conscious decision that I was in a Division II college when I left the collegiate setting. I was the only athletic trainer, and I was working all of those sports and teaching classes and serving on faculty committees. And I knew I couldn't last any longer. So when an opportunity came in to move to the collegiate setting, and he said, oh, and you only have to work 40 hours a week. And I said, well, what's that? What's that like? So that was an answer for me, but it may not be the answer for everyone. But there are ways out there for you to work. And sometimes it's just about talking to the other ATs, if you're at a secondary school, and saying, hey, do we really need to both come in at 7 o'clock in the morning? Can we not alter our schedule a little bit and share some of this time? How about we ask for a contract AT on those other nights? And sometimes it's just a matter of asking the question and brainstorming about what can be better. Sadly, our profession got stuck into we have to be the first one there and the last one to leave. And it's almost like a badge of honor. And it's ridiculous. We don't have to be that end all be all for every athlete and every program. And we just have to think around that mindset and find some work-life balance so we can practice athletic training, this incredible profession that we all love. There's a way.
There is a way. And Kathy, that, you know, I look at the amount of service that you've done for our profession. And so when we talk about work-life balance, yes, you have your job and you have your life and you have your volunteerism and you're happy. And so you can't say it's got to be a 50-50. The balance isn't on a scale. It's, are you happy? And, and that is one thing that we can all just answer for ourselves. And you find your joy and you find your fulfillment where you find it. And if somebody thinks you're crazy, well, that's up to them. So
exactly.
So I'm seeing that we're drawing towards the end of our time. And so before we go out of here, Tony, are there any other questions, burning questions in that lineup?
There is not, other than Karen Fennell thanking the group, and
we reject that. I'm just kidding. Thank you. So as we go out, I would like to congratulate Jose and Kate on the awards you received tonight. The Brandy Bridgette Scholarship is very meaningful for many of us. And as a person who grew up in St. Louis a long time ago, I'm familiar with Doc Baumann and the work that he did with St. Louis University and the St. Louis Cardinals. And so congratulations to the both of you. Congratulations to all the Iota Tau Alpha inductees, the alumni of the MAT 2000 class. It was great to see you all again. So thank you for all of that. I thank the panel for your participation tonight. It was very enjoyable.
Thank you, Kitty. Thank you, Kathy, Katie, and Father Rozier. It looks like Kathy might want to say something here real quick.
I was just going to say thank you so much for having me. It's been a great night.
Yeah, everyone have a great evening. And I'm feeling there's some collaborations coming in the future between public health and athletic training at St. Louis University. Have a great evening, everyone. Take care. Bye-bye.